Welcome back to the Deep Dive, where we extract the most vital clinical knowledge from the dense literature, giving you the shortcut to being truly well-informed.
Mm,
Today, we are undertaking a really critical mission, mastering the essentials of preoperative nursing management.
it is so important.
We're drawing all our material directly from a core medical surgical text to provide a comprehensive step-by-step guide on how we as clinicians prepare a patient for a safe surgical journey.
And this is one of the most high-stakes discussions we can have. I mean, surgery, whether it's elective or emergent, major or minimally invasive, it represents an enormous physiologic and psychological stressor for the patient.
Yeah.
So the preoperative phase, that time we have for assessment, for education, risk mitigation, it's not just important, it is the absolute foundation for preventing complications.
It sets the stage for everything that follows.
It sets the trajectory for the entire patient outcome. If we miss something here, the consequences are immediate and often severe in the OR or PCU.
So our goal today is precision. We are going to guide you through the phases of care, detailing the required documents, zooming in on specific assessments.
The really nitty-gritty stuff.
Exactly. Examining critical safety alerts like medication interactions, genetic risks, and then detailing the high-yield nursing interventions that have to be done before that patient leaves for the OR.
Okay, let's do it.
So let's start with context. We need to frame the entire surgical experience. The whole journey is called the perioperative phase. What exactly are the bookends of that phase, and how is it broken down?
So the perioperative phase is the entire spectrum of care. It starts the moment the decision for surgery is made, and it continues all the way through the post-recovery follow-up.
And it's in three parts.
It's segmented into three parts. The first, and our focus today, is the preoperative phase. This begins when the surgeon and patient agree that intervention is necessary, and it ends precisely when the patient is physically transferred onto the OR bed.
Okay, so then you hit the operating theater, which is the intraoperative phase.
That's right. The intraoperative phase runs from that transfer onto the OR bed until the patient is admitted to the post-anesthesia care unit, the PACU.
And then finally,
The postoperative phase. That begins with admission to the PACU, and it extends all the way through recovery, which could include the hospital stay, transfers, and follow-up evaluations weeks or months later.
it's important to note, though, the major practical shifts that are changing this whole experience. The text highlights two dominant trends: ambulatory surgery and the rise of minimally invasive surgery.
And those two trends are completely linked. Ambulatory surgery, you might hear called outpatient or same day, is just defined by the fact that you don't stay overnight,
You're in and out.
in and out within hours. And this shift is possible because of minimally invasive surgery, or MIS. It uses specialized instruments inserted through tiny incisions or even natural orifices.
And the result of that is just less trauma, right?
Precisely. Less tissue disruption means less physiological insult, reduced blood loss, less postoperative pain, and critically, a much shorter recovery time.
Which is safer and cheaper.
Absolutely. It drastically reduces morbidity risk and allows for safe, rapid discharge. It aligns perfectly with modern healthcare's focus on cost containment and efficiency.
Okay, so let's unpack the conceptual model that guides our actions here. The Association of Perioperative Registered Nurses, ARN, provides a foundational model for care.
And this model is crucial because it moves us beyond just, task-based care into truly holistic, outcome-driven practice. The ARN model organizes everything around four key domains.
What are those four domains?
Okay, so the four domains are safety, which is what you'd expect, preventing harm, correct side. Then physiologic responses, managing pain, fluids, temperature.
Okay.
Third is behavioral responses, so that's addressing anxiety, coping, and knowledge deficits. And the final domain is healthcare systems, which is focused on communication, resources, quality improvement, the environment itself.
I think separating those first three, safety, physiologic, behavioral, which are directly patient-tied from that fourth one, which is the system, is brilliant. It structures our diagnoses perfectly.
It does. And this model is constantly being reinforced by technology. The text really emphasizes that advances are making procedures less debilitating. I mean, the best illustration of this is the evolution to robotic surgery.
Like the Da Vinci system.
Exactly. It's a huge leap beyond standard laparoscopy.
So what are the clinical game changers with robotic assistance? Why is it really that much better than traditional laparoscopic techniques?
It's all about enhancing the surgeon's capabilities beyond what a human can do. First, you get vastly more precise accuracy for delicate dissection and suturing.
So really fine motor control.
Unbelievably fine. Second, the instruments have a better range of motion-full wrist articulation that a human hand inside a tiny incision just can't get. Third, you can access deep anatomical structures more easily. But maybe the biggest improvement is the three-dimensional visual feedback.
That 3D depth perception must be revolutionary compared to the flat 2D screen of standard laparoscopy.
It is. It dramatically improves spatial awareness, it reduces surgeon fatigue, and it allows for much finer tissue handling, which reduces trauma. That's why robotic surgery has just exploded across every specialty.
Beyond the hardware, there's the chemical side. Enhanced anesthesia methodology. What advancements there are making things safer?
Well, we've seen simultaneous safety improvements. We have far more sophisticated monitoring, modern ways to keep the airway patent, and crucially, new short-acting anesthetics.
So patients wake up faster.
Faster and clearer, which cuts down time in the PACU. We also have these incredibly effective antiemetics, which significantly reduce postoperative nausea and vomiting, or PONV.
And that's not just a comfort thing, is it?
Not at all. Severe PONV can risk airway compromise or even wound dehiscence. So mitigating that is a major safety win.
So before any of this prep can even start, the fundamental question has to be, why are we operating? And the classification by purpose really helps us manage patient expectations.
It does. We classify surgery by its objective. So is it diagnostic, like a biopsy? Is it for a cure, like removing a tumor? A repair, like fixing a wound? Or reconstructive cosmetic, like a facelift? Palliative, which is just for comfort, not a cure. And finally, rehabilitative, like a joint replacement.
Those are pretty straightforward, but the classification that really impacts our workflow as nurses is based on urgency, and understanding the difference in the nursing time window is vital.
Let's walk through them. There are 5 categories. Category 1 is emergent. This means the condition is life-threatening. Surgery has to happen without delay.
No time for teaching.
None. Assessment is happening at the same time as resuscitation. Think severe bleeding, gunshot wounds, extensive burns.
Okay, category 2 is urgent.
Right. The patient needs prompt attention, usually within 24 to 30 hours. We have a brief window to stabilize and do some essential pre-op teaching. That's for things like closed fractures or an infected wound.
Then category 3 is required.
Here, the patient needs the operation, but it can be planned. We have a few weeks or months. Think of prostatic hyperplasia or cataracts. This is where the nurse has time to schedule pre-admission testing and deliver thorough education.
Category 4 is elective.
The surgery is recommended, but if you don't have it, it's not catastrophic. It can be scheduled at the patient's convenience. Simple hernia repair, that kind of thing.
And finally, category V is optional.
This is purely personal preference, cosmetic surgery, most flexibility, lowest immediate risk, but you still need that comprehensive pre-op screening.
That framework sets the stage perfectly for the next section, the preoperative assessment. This is where we shift from definitions to actually mitigating clinical risk. And this process often starts with pre-admission testing, or PA.
PK is a huge part of the modern workflow. It's really driven by cost containment and minimizing hospital days. The PT nurse is crucial here. They do the initial assessment, collect health history, coordinate tests.
And start the education.
And start that essential patient education, often remotely. The goal is to front-load all the data gathering so the patient arrives ready on the day of surgery.
Exactly. But whether you use PED or not, there are some documents that are absolutely mandatory before a patient can get anesthesia. The most sensitive one, legally and psychologically, is informed consent.
And this is where roles get confused. The primary responsibility for explaining the procedure rests entirely with the surgeon.
The surgeon, not the nurse.
The surgeon. They have to explain the procedure, the benefits, the alternatives, and all the risks. Complications, disfigurement, disability. They must answer all the medical questions.
So the nurse's role is centered on advocacy and witnessing.
Right. The nurse clarifies information the surgeon already provided, verifies the signature, and puts it in the chart. But the vital point, the advocacy mandate, is if the patient asks a question the nurse can't answer, or if the nurse thinks the patient doesn't fully get it.
You have to stop.
You must immediately notify the surgeon. The procedure cannot proceed until that comprehension gap is closed.
And we have to emphasize that quality and safety alert. Consent must be obtained before the patient gets any psychoactive premedication.
Oh, absolutely. If the patient has been given a sedative, their capacity for judgment is impaired. That makes the consent invalid. It's a non-negotiable legal and ethical mandate.
Let's just quickly go through the criteria for a valid consent, because these are the components we have to check.
Okay, first, voluntary consent. It has to be given freely, no coercion. Patient has to be 18 or emancipated minor. If they're incompetent, you need the legal guardian.
Second is the informed subject criteria.
This means the patient gets a written explanation of everything, risks, benefits, alternatives, and they're explicitly offered the right to ask questions. And crucially, they know they can withdraw consent at any time,
Even right before the incision?
even minutes before. And third, the patient must be able to comprehend. If there's a language barrier, you need a trained medical interpreter. It's not just about getting a signature, it's about a true meeting of the minds.
Okay, the second non-negotiable document is the history and physical, the H&P. And the text sets some pretty specific timing standards for this.
That's right. The comprehensive H&P has to be done within 30 days of the surgery date. And for outpatients, it has to be updated within 24 hours of surgery. This prevents us from relying on old data.
Makes sense.
The H&P itself has everything: history of the illness, surgical, medical, social, family histories, allergies, meds, the whole plan of care.
This leads us right to the high-stakes part of the assessment, identifying specific surgical risk factors. We need to scrutinize these systems because underlying conditions can dramatically increase operative risk.
We have to assess these systematically. Let's start with the cardiovascular system. We're looking for things like coronary artery disease, a previous MI, heart failure, arrhythmias, a history of VTE.
Because the stress of surgery can trigger a cardiac event.
A potentially fatal one. The catecholamine release is massive.
And what about the body's filters, the liver and kidneys?
Equally critical. The liver is where most anesthetics are metabolized. So, hepatic diseases like cirrhosis can severely impair drug clearance, leading to toxicity. And decreased renal function limits the body's ability to excrete drugs and manage fluids.
And then there are those system-wide conditions and extremes.
Yep. We have to assess endocrine risks, especially uncontrolled diabetes. We look at extremes of age, extremes of weight obesity significantly increases risk, and any nutritional deficits are red flags. Finally, any active infection or immunologic abnormalities often means we have to postpone, at least for elective cases.
Okay, that brings us to the next section where we shift focus to specific assessments for high-risk, nuanced conditions. Let's start with allergy and genetics.
Latex allergy is a classic safety issue. It can manifest as anything from a simple rash to life-threatening anaphylactic shock, and we need to recognize the non-obvious indicators.
Like food allergies.
Exactly. The text highlights a crucial clinical nugget. Patients with known allergies to kiwi, avocado, banana, or chestnuts might have a cross-reactivity with latex.
That cross-reactivity point is huge, and the screening questions are key, right?
The screening has to be direct. Have you ever had swelling or itching after using a rubber glove or playing with balloons? If the risk is there, you initiate a rigorous latex-free protocol immediately.
Okay, next, let's talk genetic considerations. Some inherited disorders can dictate how a patient metabolizes anesthesia, making them super high risk. The big one is malignant hyperthermia, or MH.
MH is a life-threatening, often inherited condition. It's basically an uncontrolled increase in skeletal muscle calcium that leads to a hypermetabolic state.
So how do we screen for that?
The key clinical assessment here is a deep dive into the family history. The nurse has to ask about unexplained deaths during surgery, family history of high fevers, muscle rigidity, or any unusual reactions to anesthesia.
And if there is a risk, what's the earliest sign the anesthesia team is looking for?
The earliest and most sensitive sign of MH is often a sudden rapid rise in end-tidal carbon dioxide, EtCO2. Then you see tachycardia and muscle rigidity, and then hyperthermia.
And knowing the risk means you're prepared.
It means the OR is prepared with non-triggering agents, and the definitive treatment, dantrolene, is right there. This preemptive assessment is truly a life-saving nursing action.
Moving to nutritional and fluid status, the goal is clear. You need good nutrition and hydration to heal. How do we move beyond just a simple BMI check?
The assessment has to be comprehensive. BMI, waist circumference, looking for signs of cachexia or obesity, checking for specific deficiencies. Optimal nutrition is just non-negotiable.
The book gives us a detailed inventory of the nutrients crucial for wound healing. Let's expand on the function of each.
Okay, let's start with big players. Protein. It's essential for synthesizing collagen, which is the structural matrix of the wound.
And a deficiency leads to
Delayed healing, increased infection rates, and a real risk of wound dehiscence. We also need arginine, a specific amino acid that's a substrate for that collagen synthesis.
And what about our energy sources?
Carbohydrates and fats are the primary energy source. This is crucial because if the body doesn't have enough glucose, it will start breaking down protein for energy, diverting it away from the repair process.
Okay, let's talk vitamins. Vitamin C.
Indispensable for capillary formation and collagen maturation. A deficiency causes increased capillary fragility and severely delayed healing. Then you have vitamin A, which supports the inflammatory response in the wound.
And the trace minerals.
Zinc is a cofactor in over 300 enzyme reactions. It's vital for DNA and protein synthesis and immune function. A deficiency cripples the immune response. And then vitamin K is required for normal blood clotting.
This all ties into NPO status. We mandate it to prevent aspiration, but it's a double-edged sword, isn't it? Especially after a bowel prep.
It is. Prolonged fasting, especially with laxatives, significantly increases the risk of dehydration and electrolyte imbalances. The nurse has to not only confirm NPO status, but also monitor for signs like poor skin turgor and oliguria.
Okay, moving to the mouth. Dentition. Why do we spend so much time assessing teeth and prostheses?
It's not trivial at all. Any decayed or loose teeth, dentures, crowns, they pose a dual risk. First, they can be dislodged during intubation and block the airway, an emergency.
And second.
Second, poor dentition is a source of chronic, low-grade infection that can enter the bloodstream and cause systemic infection post-op.
For respiratory status, if a patient comes in with an active upper respiratory infection for an elective case, what's the default action?
The default is often postponement. An active infection significantly increases the risk of laryngospasm, bronchospasm, and postoperative pneumonia.
And we have to use that pivot to address smoking cessation.
Absolutely. Smoking increases the risk of nearly every postoperative complication you can think of. Poor wound healing, SSI, VTE, pneumonia. For high-risk elective procedures, surgery might even be delayed 6 to 8 weeks to allow for improvement in lung function.
And lastly in this section, endocrine and immune function.
For patients on long-term corticosteroids, the key risk is adrenal insufficiency. If the stress of surgery happens without enough cortisol, they can go into cardiovascular collapse. The team will often order a stress dose of 5E corticosteroids to prevent this.
And for the diabetic patient?
Diabetes demands stringent control. Surgical stress spikes blood glucose. Hyperglycemia messes with leukocyte function, impairing the immune response and increasing the risk of SSI. So strict glycemic control is critical.
This brings us to a huge safety moment, medications and psychosocial preparation. This is where we prevent catastrophic drug interactions.
This cannot be overstated. The nurse's role in getting a complete and accurate medication history is paramount. We need everything: prescription, OTC, and especially herbal agents.
Let's verbalize some of the critical safety alerts around these medications. Start with the ones that affect the cardiovascular system.
Well, we already covered corticosteroids and the risk of circulatory collapse. Diuretics are also dangerous because they can cause hypokalemia, which heightens the risk of respiratory depression and cardiovascular instability with anesthesia.
What about medications affecting coagulation? This is a major area of risk.
It is. Anticoagulants like warfarin or platelet inhibitors like aspirin and clopidogrel often have to be stopped 7 to 10 days before surgery. The nurse must verify that the patient followed that stopping schedule.
And for chronic pain management?
Patients on long-term opioids might have a tolerance that changes their response to post-op analgesics. That needs to be communicated so the pain plan can be adjusted. And again, for insulin, careful FAV management is usually required.
As crucial as prescription drugs are, herbal supplements often slip through the cracks. Patients don't see them as medicine.
They are a huge hidden risk. The American Society of Anesthesiologists advises that all herbal products be stopped at least 2 weeks before elective surgery.
Let's detail some of the specific risks. Which ones affect coagulation?
So garlic, ginkgo biloba, ginseng, and vitamin E all have antiplatelet or anticoagulant effects. They increase the risk of serious perioperative bleeding.
And what about those that affect the central nervous system?
St. John's wort, kava kava, and valerian are commonly used for anxiety or sleep. They all carry a risk of prolonging the effects of anesthetic agents. And ephedra, a stimulant, can cause dangerous increases in blood pressure and heart rate.
Okay, now we move to psychosocial factors, anxiety and fear. This isn't just a compassionate consideration, is it? High anxiety has documented negative physiological consequences.
That's the key clinical insight. Severe anxiety triggers the acute stress response. You get a release of cortisol, epinephrine.
Which raises blood pressure, heart rate?
Exactly. It elevates blood pressure, heart rate, cardiac output, blood glucose. Severe anxiety pre-op is directly linked to poorer outcomes, delayed healing, exaggerated pain, and an increased risk of infection because stress hormones suppress immune function.
So as the nurse, how do we assess and manage that fear when it might be subtle?
You have to be empathetic and observant. Fear can manifest as asking the same questions over and over, or withdrawal or irritability. The nurse's guidance should focus on addressing the patient's specific fears and providing concrete information to demystify the process.
The assessment also has to include their support system and their readiness to learn.
Especially for cognitively impaired patients. The legal guardian has to be the primary focus of education and consent.
And finally, we have to acknowledge spiritual and cultural beliefs for truly holistic care. The nurse is a crucial advocate here.
This requires so much sensitivity. For example, some cultures value stoicism, so a patient might rate their pain low despite being in clear distress. We have to interpret those cues correctly.
And what about high-risk issues like religious objections to treatment?
Yes, the most critical example is Jehovah's Witnesses declining blood transfusions. These objections have to be meticulously documented, verified, and communicated clearly to the surgical team, ensuring all alternatives are prepared.
That transition takes us right into preoperative nursing interventions. This is where we move from assessment to action.
And the goal here is multifaceted. Manage anxiety, prevent pulmonary complications, and prevent VTE. Education has to be individualized, using verbal instruction, written materials, and the most vital component, return demonstration.
I appreciate the emphasis on explaining sensations, not just procedures. Why is that so effective at reducing anxiety?
Because the unknown is often more frightening than the known. If you tell the patient, the pre-medication will make you feel lightheaded and drowsy, they are less likely to panic when it happens. It promotes a sense of control.
The most critical intervention for post-anesthesia recovery is respiratory preparation. Let's detail the techniques.
The foundational technique is diaphragmatic breathing. The patient is in semi-Fowler, hands on their lower ribs. The instruction is specific. Exhale fully, then take a slow, deep breath through the nose, allowing the abdomen to rise.
And the retention period is key.
Absolutely. They have to hold that deep breath for a count of 5. The rationale is to strengthen the diaphragm, which prevents the major complication of atelectasis, the collapse of the alveoli.
And equally important is the coughing technique, especially for abdominal incisions. We have to teach them how to splint the incision.
Splinting is vital. The patient sits, leans forward, and interlaces their fingers across the incision site, holding it snugly. Then they do 3 sharp hacks, followed by a strong cough. This mobilizes secretions to prevent pneumonia.
Next up, mobility and VTE prevention.
Early ambulation is the ultimate goal, but preoperatively, we teach them leg exercises. While in bed, they should extend and flex the knee and hip and trace circles with their big toe to aid venous return.
And repositioning.
We teach them how to safely turn to the side, using the side rail. This minimizes strain on the incision and helps them shift position post-op, which is essential for skin integrity.
Pain management education also has to happen preoperatively.
Yes, the nurse introduces a pain scale and ensures the patient understands it. We differentiate acute post-op pain from their chronic pain, and we discuss the methods PCA, epidural, or oral agents. The goal is to set expectations.
Finally, equipping the patient with cognitive coping strategies.
These are non-pharmacological methods to reduce tension. We can teach guided imagery, distraction like reciting a song, and optimistic self-recitation. Things like, "I know all will go well."
The text also references complementary therapies.
It does. Music therapy, aromatherapy with essential oils like lavender, and even things like Reiki. The nurse's role is to assess patient preference and integrate these if they're available and requested.
Okay, now we move into immediate preoperative preparation and safety. We have to address specific populations, starting with older adults.
The older adult has reduced physiological reserve across the board. They're highly susceptible to hypothermia. The nurse has to do a meticulous fall risk assessment, checking for a history of falls, sensory impairments, and the use of sedating premeds.
And cognitively, what adjustments are needed?
Due to potential memory deficits, education has to use multiple formats: verbal, large print, return demonstration, and you really need a support person there for complex instructions and consent.
For ambulatory patients, the window is compressed, and the discharge plan becomes a crucial safety point.
You have to rapidly verify they understand the path, pre-op to OR to PCU to home. And crucially, you have to ensure their follow-up home care arrangements are secured and verified before they're admitted.
Okay, let's talk general safety standards from ARN and the Joint Commission.
The nurse's actions are central here. Correct patient ID using 2 identifiers: medication safety, infection control, and participating in the process to ensure the surgical site is marked by both the patient and the surgeon.
Next, NPO status and bowel prep, the specific rules.
Okay, so clear liquids are generally allowed up to 2 hours before an elective procedure. But it's 6 hours after milk products and 8 hours after fatty foods or meat because they delay gastric emptying.
What about the concept of carbohydrate loading?
This involves giving patients special carb-rich drinks a few hours before surgery. It's been shown to reduce insulin resistance, decrease length of stay, lower PO&V, and even reduce pain scores for non-GI surgeries.
And is bowel preparation standard practice anymore?
No, not routine. It's typically reserved for abdominal or pelvic surgery where visualization is crucial. It might involve an enema or laxative and maybe antibiotics to reduce intestinal flora.
Moving on to skin preparation.
This usually means a full-body bath with antimicrobial soap the night before. And for hair removal, a critical safety alert. You must use electric clippers, never a razor. Razors cause microabrasions that significantly increase infection risk.
As the patient is moved to the immediate pre-op area, what are the final checklist actions?
It's meticulous. We confirm ID, apply alert bracelets. Patient changes into a gown and cap. All nail polish and artificial nails have to be removed because they interfere with monitoring devices.
What about valuables and prosthetics?
All jewelry, dentures, hearing aids, glasses, removed and secured. Jewelry has to come off to prevent burns from the electric cautery. And finally, the patient must void immediately before transfer to the OR.
Let's discuss the critical timing of medication administration, particularly antibiotics.
The timing is crucial. For prophylactic antibiotics, the administration has to be timed precisely to ensure the drug reaches its peak efficacy, the highest concentration in the tissues and bloodstream, immediately before the incision.
One final safety element before transfer: preventing unintended perioperative hypothermia, or UPH.
UPH is a major concern. It's a core temp below 36 degrees C. The risks are substantial: increased SSI rates, increased bleeding, cardiac dysfunction, and delayed wound healing.
So how does the nurse actively prevent this?
Prevention starts in the pre-op area with pre-warming. We use pre-warm blankets, forced air warming devices, warmed IV fluids. There's compelling nursing research showing that aggressive pre-warming dramatically reduces the incidence of UPH. It's an entirely nurse-driven intervention with a massive clinical benefit.
That brings us to our final section, attending to family needs. Even as the patient is whisked away, we can't forget the support system.
Family members are often highly anxious. Communication is essential. We have to provide realistic expectations for the duration of the entire process, reminding them that OR time includes anesthesia, prep, and closure, not just the cutting time.
And when the patient is in recovery, how do we prepare the family for what they're about to see?
The family should be informed about potential equipment before they see the patient. Seeing someone connected to IV lines, catheters, monitors, it can be shocking. Providing that context up front reduces their anxiety.
And we must reinforce the distinction in roles one last time for the family.
Crucially, the nurse provides explanations about post-op observations and pain management, but the surgeon is solely responsible for relaying surgical findings, complications, and the prognosis. That maintains professional boundaries and accurate communication.
So if we review the expected outcomes, the foundation we built ensures the patient achieves relief of anxiety, decreased fear, and successful demonstration of exercises. These are all nurse-sensitive outcomes.
If we connect this whole process back to the bigger picture, the preoperative phase is the most powerful mechanism nurses have to proactively influence every single patient outcome. We identify silent risks and mitigate them before the patient even touches the OR table. That is surgical safety advocacy.
Absolutely. It's all about meticulous preparation. And thinking beyond the mandated checklist, here is a final provocative thought for you, the well-informed clinician, to mull over. Considering the high percentage of patients, especially those with a higher BMI, who have undiagnosed obstructive sleep apnea, a huge risk factor for difficult intubation and post-op respiratory failure, how might integrating a standardized screening tool like the Stop-E-Bang questionnaire into every required preoperative H&P, regardless of the procedure, fundamentally elevate patient safety?
A fantastic point. It forces us to proactively screen for a silent killer before it becomes an anesthetic crisis. That proactive posture is what separates competent care from exceptional care.
Thank you for joining us on this deep dive into preoperative nursing management. We hope this comprehensive review reinforces your essential clinical skills and empowers you to master this critical phase of patient care.
Keep synthesizing this vital information and applying these nuggets of knowledge to protect your patients.
Until next time.